Okay, good afternoon, everyone. So nice to see that many people logging into this webinar this afternoon. On behalf of the Allied Health Professionals Committee of ESCON, I'd like to welcome you to this webinar on the MCT diet in gastroenterological conditions. Tonight we have two speakers. First, we'll have Jutta Köglmeier, who's a pediatric gastroenterologist at the Great Ormond Street in the UK. She's also in the nutrition committee of ESCON. And then we have Elena Banci, who's a pediatric dietitian at the University of Myers Children's Hospital of Florence. After the webinar, we will have a Q&A part where you can ask your questions. You can write them in the chat or the Q&A option at the bottom line. So Jutta, please go ahead. I'll hand over to you.
Yeah, so thank you very much. So in the next 45 minutes or so, Elena and I will talk you through about MCT diets from a pediatric gastroenterology and pediatric dietitian's point of view. So I will talk about how lipids are absorbed, so long-chain triglycerides versus medium-chain triglycerides, what an MCT-rich diet actually means and what it involves, particularly the rationale behind using this from a pediatric gastroenterologist's perspective. And then I hand over to Elena, who will focus on clinical cases and the practical approach by the dietitian. Next slide, please. So lipids consist of long-chain triglycerides, LCTs for short, and medium-chain triglycerides, MCTs. The absorption of LCTs is bile-dependent, and they make up most of the fatty acids consumed in a typical Western diet. They originate from animal or vegetable oils and other fat sources, and they contain 12 or more carbons. Medium-chain triglycerides, or MCTs, are mixed triacylglycerols of fatty acids with a chain length of 6 to 10 carbons. They normally represent only a very small amount of the fats in the Western diet. Since the 1950s, it's been possible to synthesize MCTs by hydrolysis of, for example, coconut oil or palm kernel oil. And then the medium-chain fatty acids can be filtrated, and then re-esterification can take place. So they've now become available, and that's helpful for us because we can use these MCTs in diets. MCT digestion starts in the stomach, and they're directly absorbed across the enterocyte into the portal circulation. So assembling into chylomicrons for transport through the lymphatics is not required. They can help to increase fat uptake and allow for a faster energy supply. But what is important to know is they lack essential fatty acids. Next slide, please. So how would one start if you think the first year of life, 0 to 12 months? Unfortunately, breast milk as such is not suitable for infants following a minimal LCT diet because the fat in breast milk is mainly LCT, so estimated around 4 grams per 100 ml of breast milk. But the exact LCT intake would actually be quite difficult to measure as the fat content of breast milk varies between mothers and depending on what they've eaten themselves. And the composition of human milk also changes during a breastfeed, with the hind milk being higher in fat. However, I think this is really important to say, breastfeeding is, of course, the preferred source of nutrition for infants because of its many health benefits. So people thought about offering skimmed breast milk as a feeding option for infants. Feeding options for infants following a low MCT diet. So is this actually effective? Well, there is some information available in the literature. This is, for example, a study from 2015 published in in the Journal of Parental and Enteral Nutrition, and they had 16 infants with a chylothorax, and I come back to that later, what that is. And they split them into two groups. So in the first group were 8 infants who received their mother's modified expressed breast milk. So the fat layer was removed via centrifugation, and then MCTs, nutrients, essential fatty acids added to provide about 74 kilocalorie and 1.4 gram per 100 milk of the modified breast milk. And then the other group received the standard off-the-shelf available MCT-rich formula. And the treatment was successful in both, in a sense that the chylothorax resolved in both groups after 6 weeks. But unfortunately, the growth rates of the infants fed the modified expressed breast milk was significantly slower than that of the formula-fed group who had the standard MCT-rich formula, despite the breast milk having been more fortified. So I think there's more thought needed. At the moment, it's actually not possible to modify the fat content of EBM in most clinical settings. For example, I work in the United Kingdom. It's not possible in any of the centers, but there are centers in the United States and Canada who have started this, or which have started this process, and they set up protocols. Next slide, please. So from the literature, there's varied evidence and information available on this fat-modified or skimmed breast milk. A few studies have looked at the macronutrient content. Unfortunately, there's little to no information on the micronutrient content. And for example, at Great Ormond Street, where I work, we don't even have a suitable breast milk analyzer, which could check the micronutrient profile of skimmed EBM. So we're not using it, but we think about considering this in the future. So what formulas are available? Well, I have taken out the company's label, but there's one that certainly I'm very familiar with is called Monogen, which is a very high MCT content of 84% with a very low LCT content of 16%. The macronutrients have an otherwise reasonable profile, and the protein source is whole whey protein. Next, please. Thank you. And there are also other formulas from us. So LipiStart is another one that I'm not familiar with, but I guess depending on where you work, you may use this one from another company, or I'm sure there are many on the market. But here's to be said, just as an example, that has a slightly, sorry, not so fast, Elena, please. Sorry, could you go back, please? Thank you. Has a higher LCT content, 20% compared to the other feed. Next slide, please. So if you think about these diets, you have to think about essential fatty acids, because I said earlier on that MCTs do not contain these. But as long as these infants are on one of those formulas, which are usually supplemented or already supplemented with essential fatty acids, it's not necessary to supplement it separately. But it's also important to be aware of the LCT contents of these formulas so that the infant doesn't exceed their daily LCT allowance. The next slide, please. And when you consider the volume of formula that provides 1 gram LCT, just as an example, with these two feeds, LipiStart 175 ml would provide a gram, and Monogen 285 ml. So it's the lowest LCT content. And if you're thinking in volumes that particularly younger infants have to achieve, it may just be a favorable feed, but there may be others on the market. And I think it's important to know if a particular very low LCT feed is not available, that a formula may have to be adapted to keep the recipe at the desired LCT level. So let's say 2 gram a day. And that can be achieved if you dilute the formula to provide the maximum amount of LCT allowed in a day. And then you may just have to add, sorry, could you just go back, please? Maybe I just say when to change the slide. Thank you. And other proteins, essential fatty acids, carbohydrates, electrolytes, and micronutrients may have to be added, I think. And the dietitians correct me, is that wrong? But as I'm aware at the moment, MCT peptide has been discontinued. So children with a cow's milk protein allergy who may need an extensively hydrolyzed or amino acid formula are a bit stuck, and they may require a modular feed. Emsogen is an AA-based MCT feed, but that's only licensed from for children above 1 year of age. So that would certainly need some very close dietetic input and perhaps some help from the dietetic kitchen. Next slide, please. So when complementary feeding on a low LCT diet starts, the minimal LCT formula will continue to meet most of the nutritional needs and will be an essential part of the infant's diet until they're a year old. And weaning should proceed as per the Department of Health guidance in terms of when to start and how to progress textures. But I think, again, it's very important that Elena and her colleagues are involved here, because a minimal LCT weaning diet should really be supervised by a dietitian who's familiar with the diet. It's also important to say that most manufacturers' infant jars and foods, which you can buy over the counter, suitable on this diet, are fruit and veg based and are not very nutrient dense. And other readily available infant foods usually contain much food, and they should hence be avoided. Next slide, please. So what would be suitable weaning foods if you think very practically, sort of depending on when you start, let's say 4 months or a little bit later? So plain baby rice mixed with the minimal LCT formula, that's certainly what would happen in the UK. Baby rice is a first complementary food, but I know it varies from countries. Then pureed vegetables, so potato, other root vegetables, cruciferous plants, and then fruit purees. And then when the child gets a bit older, 6 months or a bit later, thicker beans, peas, lentils, dal can be introduced. Mashed or pureed skinless chicken and turkey, so the white meat only, because the skin of chicken or other parts of the bird contain more LCTs. Mashed plain white fish or tin tuna, but tin tuna in spring water, not in oil. Or very low-fat cottage cheese. But what it's important to know here, and this is again where the dietitian is so important, some of these foods obviously contain fat, they will contain LCT, so it's important to know the overall amount and how much the child is allowed in the day. And then as the child gets older, 6 to 9 months, obviously the textures progress, more foods are introduced in addition to the foods I've already mentioned, finger foods. Bread, but again, I think it's important to know some breads are actually fortified, so to be sure that the LCT content is not exceeded. Thank you. Next slide, please. So what do you do in children who are a year old and older? Well, I think at the initial appointment that a child has with the clinician, with the dietitian, it's important to set to agree the LCT restrictions, so 5 to 10 gram a day. And of course, that's at the start, but that may be adjusted according to what symptoms the child has, how they grow, and how practical this is for the family at home. Children who are following an oral minimal LCT diet will require an essential fatty acid supplement, simply because that it is otherwise very, very difficult to achieve the essential fatty acids required. So just as a practical example, to calculate, let's say, walnut dose for a 2-year-old girl, walnut oil is quite cheap, it's fairly tasteless, so that's very commonly used, and it's easy for family to get just over the counter. So if you think about if you have, let's say, a 2-year-old girl, so the ARR 930 kilocalories per day, what you do is you divide that by, so basically you calculate the dose of walnut oil as 0.1 mil per 56 calories of the ERA. And so 950 divided by 56, and that times 0.1 would be 1.7 mil. Then we need to know how much LCT does 1.7 mil of walnut oil contain. Well, it's 0.92 gram per mil. So if you then do the calculations, so 1.7 mil walnut oil times 0.92 is 1.6 gram of LCT. And you have to take this off the overall daily LCT allowance, which then leaves this particular child with 3.46 gram per day, which is actually very, very little. And I come back to that later. Thank you. Next slide. So which feeds are allowed freely where you don't have to count? Well, all vegetables, so fresh, tinned, frozen, pickled vegetables in vinegar, so we're thinking beetroots or gherkin, all fruit, apart from avocado and olives because they're very high in LCT. Bottled fruit sauces or compote, jellies, sweets, wine gums, boiled sweets, fruit sorbets, sugary foods, egg whites or meringue, as I said, some sauces, tomato ketchup, vinegar, fat-free mayonnaise, herbs, fruit juices, Nesquik powder, but not the chocolate, so fizzy drinks. So a lot of those foods, I'm sure a lot of children like, but it's very limited what you can actually give freely. Next slide, please. And that, I think this slide demonstrates how difficult a diet actually is. So foods not allowed or in extremely minimal amounts would be whole or semi-skimmed milk. Skimmed is allowed. Cream, full-fat cheese, creamy sauces, full-fat yogurt, fromage frais, instant milk drinks, whole eggs, sausages, salami, burgers, oily fish, fish fried in butter or fish tinned in oil. So you can imagine that makes the diet actually not that easy to follow. Next slide, please. Next slide, please. Yeah, foods which must be counted. So how do you actually start? So let's just see something very simple. Let's say a shop bought bread. Yeah, manufacturers' foods have a nutritional label giving the fat content per 100 gram of the product. And it should be what we are using for simplicity is the total fat for the calculation, not saturated fat. So if you see here, the total of 100 gram of bread would be 2.3 gram. Okay. And then to work out the food is suitable for a low minimal LCT diet, then you'll have to work out the fat content per portion. Yeah. Or it may be easy here if you know the fat content per slice, if that's your portion. So here a slice is 40 gram of bread, and that has 0.9 gram, yeah, but of fat. But also you can work out the amount of food that would provide you with 1 gram of fat. So if you divide 100 with the fat content per 100 gram, and that gives you the amount of foods in gram that contains 1 gram of fat. So if you do this here, 100 by the 2.3 per 100 gram is 43 gram of bread. So 43 gram of bread. So a little bit more than 1 slice provides you 1 gram of fat. Next slide, please. So how do we use this actually in practice in gastroenterology? Well, sort of epilepsy, metabolic diseases, that's really managed by my colleagues in the hospital, certainly not by me. But for example, I do inpatient parental nutrition rounds, so chylothorax on the cardiac intensive care wards, or intestinal lymphangiectasia, exocrine pancreatic insufficiency, children with short bowel syndrome, and intestinal failure associated liver disease would be the conditions I manage with a diet like that. Next slide, please. So intestinal lymphangiectasia, for example, is one that leads to loss of plasma proteins in the intestine. But it's important to say that protein loss is a symptom, not a disease in itself. So I think it's important to consider the underlying causes and treat accordingly. Next slide, please. And intestinal protein loss depends according to the underlying problem. So for example, damage to the intestinal mucosa due to erosive or non-erosive causes, or lymphatic abnormalities, which can be acquired and or congenital. And Elena will give us a beautiful case presentation on this later. Next slide, please. So this slide here shows the structure of the normal intestinal villi and the pathological mechanisms causing protein loss. So circulating proteins in cells egress from the capillaries to the interstitium and are collected by the lymph vessels, including lacteates, and they transport it back to the blood. In disorders summarized as protein-losing enteropathy disorders that can involve one or more, so up to 3 mechanisms, which are shown here. And the rate-limiting step for protein loss differs in each condition. So it can be capillary diffusion of proteins into the interstitium in diseases with erosion, or epithelial permeability in non-erosive intestinal disorders. And thirdly, leakage and ruptures of dilated lacteals in intestinal lymphangiectasia. And next slide, please. This picture here shows mechanisms of enteric protein loss in different disorders. And intestinal lymphatic circulation in the healthy state, and then in different cases of intestinal lymphangiectasia. So in each disorder, the circulatory network is affected differently, but all the disorders have an effect on the anterograde flow in the distal channel. So eventually in all 3, the flow is reversed, and that causes dilatation and ruptures of the lacteals, and therefore they decompress the system at the expense of lymph wasting. And then there are primary conditions, so congenital conditions due to genetic abnormalities, and then secondary causes of intestinal lymphangiectasia, for example, after surgeon cardiac surgeries, Fontan procedure in children with constrictive pericarditis. Next slide, please. Okay. So erosive or non-erosive is damage to the intestinal mucosa, and then the primary or acquired intestinal abnormalities. Next slide, please. And there are a lot of examples, but one I'm sure we're all familiar is for an erosive one. Damage to the intestinal mucosa would, for example, be inflammatory bowel disease or an infection. A non-erosive one would, for example, be celiac disease or an allergic-induced enteropathy. Next slide, please. And then the congenital lymph abnormalities. Next slide, please. They're caused by specific gene mutations, and they lead to an abnormal lymphatic development. So they cause lymphangiectasia, and they can be focal or diffuse. I think knowing the genetics is helpful, certainly for the future. Perhaps there are potential treatment options in terms of gene therapy, but depending on what the underlying cause is, they're also slightly differently managed. Next slide, please. So I think protein-losing enteropathy, or PLE, due to, depending on what the underlying cause is, I think it's important to diagnose this, because the underlying cause, for example, in celiac disease, something very simple, removing gluten from the diet would be the treatment. So you don't need to venture out on an MCT, low LCT diet. But I think many of these children, if they're very severely affected, we're thinking about, for example, Hennekam syndrome, and we'll come back to that. They often have, because they have such massive fluid shifts, fluid and electrolyte imbalances, which need to be corrected. They can be very underweight, nutritional management, and they also lose fat soluble vitamins and trace metals. They need to be restored. Next slide, please. And they are symptomatic treatments. You just simply replace your albumin, but as you pour it in, it tends to come out again of the gut. There are drugs, octreotide with inconsistent efficacy, but I certainly use them. These children also leak immunoglobulin through their gut, so they can have nasty infection. You may have to give infection prophylaxis or immunoglobulin replacement therapy, but again, they continue to leak. Next slide, please. And the diet is, again, really an absolute main factor of the management of this condition. They're particularly effective when a primary lymphatic flow disorder is involved. So what you would do is a high protein, low fat diet with an MCT predominance and little LCTs, but mainly MCTs and short chain triglycerides. Thanks. Next slide, please. Chylothorax is another condition where I would use this. Next slide, please. Not that I look after them myself, but as I said, I see them on the cardiac intensive care wards. A chylothorax is characterized by the leakage of chyle into the pleural space of the chest from the thoracic lymph duct. And lymphatic vessels of the digestive system normally return lipids absorbed from the small intestine via the thoracic duct, which ascends behind the esophagus to drain into the left brachiocephalic vein. But if for whatever reason normal thoracic duct drainage is disrupted, let's say either due to obstruction or rupture, the chyle can leak and accumulate within the negative pressured pleural space. And if children are following a normal diet, this fluid collection can sometimes be identified by its turbid, milky white appearance, as the chyle contains emulsified triglycerides. And in children, this is most commonly seen after cardiac surgery. It's been described in newborns as well who've been rapidly delivered due to the very fast increased venous pressure. And then there are less common causes, so children on ECMO or chest trauma, malignancies. There are rarer causes. We won't go into detail today. Next slide, please. And then the image on the left shows the chyle in the interpleural space, and the one on the right outlines the normal anatomy of the thoracic duct. Next slide, please. So chylothorax after cardiac surgery in children is associated with an increased duration of postoperative mechanical ventilation, more days on intensive care, and therefore increased cost to the healthcare system, but also higher morbidity and mortality for the children. So the main treatment goals of a chylothorax is really to decrease and eventually cease the thoracic lymph flow, and allow for the lymphatic vessels to heal or develop. Next slide, please. So how is this treated? Well, depending on the underlying cause, there are many treatment options. Medication may be one, dietary modification, in severe cases, surgical treatment for perhaps if the thoracic duct was damaged, it may have to be ligated. Next slide, please. And the dietary management of a chylothorax is either the MCT diet or total parental nutrition. Enteral feeding with an MCT diet, fat-modified breast milk if it's available, or low-fat diet are options. And the rationale is due to what I said at the beginning. Conventional fats are absorbed by the lymphatic system. They require chylomicron formation, whereas the medium-chain triglycerides are directly absorbed by the intestinal cells and transported into the portal system without the chylomicron formation. And the MCT-based diet therefore helps to reduce lymphatic flow along the thoracic duct and can therefore minimize the chyle output drainage, allowing for the chylothorax to resolve. But if the diet fails, then total parental nutrition and gut rest is sometimes what we need to use. Next slide, please. And what we do at Great Ormond Street, and I'm sure people have other treatment protocols. So in the first 48 hours after surgery, we monitor and record the chest drain losses, and we use a feeding protocol depending on is the child allowed to feed orally or enterally, on what kind of surgery the child had. And then we have the high-worth, the standard feeding protocol. So standard, any child with a low risk of an ischemic insult to the gut, but those with a high risk for an ischemic insult, we are more cautious. And then sort of 48 to 72 hours post-op, if feeding has been started and the drain losses are more than 5 mL per kilo per day, or they look like chyles or milky cloudy, we think about an underlying cause for this, or venous thrombi, or elevated right-sided pressure, or has the thoracic duct during the cardiac surgery been damaged. And then we measure the fluid for triglycerides and the body cell content. And if the fluid triglycerides are more than 1.1 millimole per liter, and the body fluid cell count has more than 1 greater to 10^9 white cells and more than 80% lymphocytes, this is per definition chyle. Next slide, please. And if the chylothorax is confirmed and the chest drain output is less than 10 mL per kilo per day, that's considered a low output drain. we start a low LCT, high MCT diet for 2 weeks. And in that time, the mom, if she's breastfeeding, can express her own breast milk. So the medium output would be losses of 10 to 20 mils per kilo. So we give this diet for longer, for 4 weeks, and then that can, then if everything resolves, then result in switching back to a normal oral diet or infant formula preferred breast milk. But in a high output chest strain of more than 20 mils per kilo, we keep children nil by mouth for 7 to 10 days and start total parental nutrition. Sometimes we also use drugs. And if the drain output has come down then to less than 20, then you basically step up or down, as you could say, in the pathway, and you start the minimal LCT, high MCT diet for 4 weeks. And if the chest drain remains high, then you could continue the parental nutrition and you consider surgery. Next slide, please. There are other conditions as well. For example, exocrine pancreatic insufficiency. An MCT diet can be helpful in certain circumstances, so cystic fibrosis being the most common cause of exocrine pancreatic insufficiency in children, followed by Shwachman-Diamond syndrome, but there are other rares I don't want to go into. Next slide, please. And I think the non-pulmonary symptoms of cystic fibrosis, CF, so they have been long known. They are described at the first third of the last century. So exocrine pancreatic insufficiency, reduced to maldigestion, malabsorption, malnutrition, and growth failure. And that's worsened by reduced bicarbonate secretion at a CNA level in these children. Next slide, please. And that's why traditionally, before CFTR modulators have become available, the CF diet was also one with a high-calorie, high-fat diet with pancreatic enzyme replacement therapy. I think since the CFTR modulators are available, we are moving more towards a healthy diet, and then fat-soluble vitamins and minerals have to be supplemented. Next slide, please, because there is good evidence that BMI and lung function are directly associated. Next slide, please. But if you have children who, for whatever reason, require an enteral tube feeds, it gets a bit more difficult to replace pancreatic enzymes. And the dose and the regime depends on what type of feed is chosen, what fat content the feed has, so long versus medium chain triglycerides, whether the feeding regime is continuous or a bolus feeding regime. There's actually very little evidence of optimal administration of pancreatic enzyme replacement with enteral feeds, but good practice is to give the enzyme replacement orally if the infant can take that, or the child at the start of the bolus feeds, and then every 4 to 6 hours with continuous feeds. But you may imagine that's perhaps not very practical. Let's say you're on an 18-hour continuous feed, then the mother would, or the parents would have to get up probably in the middle of the night. And there is, again, less PERT required with an MCT-rich formula, and this is where these formulae really have a role. Next slide, please. And then I think just at the very end, before I hand over to Elena, there is also a rationale behind different dietary fats in short bowel syndrome, so another condition that I see very frequently as a pediatric gastroenterologist. So it's important to say that LCTs have a role. They enhance bowel adaptation. They stimulate the secretions of gut hormones, which mediate the ileal and jejunal break, resulting in slower transit time. And for example, your GLP-2 in particular, we now have available as medication as well, which we know enhances adaptation further. And they also have an anti-inflammatory effect and improve the splanchnic circulation. Next slide, please. But we do use MCTs in short bowel syndrome for this very reason, that they're directly absorbed across the enterocyte into the portal circulation. Digestion starts in the stomach. Imagine if you have a child who's lost a lot of intestine, that could be helpful. And they increase fat uptake and provide energy faster, particularly in patients with an intact colon. They can improve fat absorption. They may be beneficial in patients with bile acid deficiency or exocrine pancreatic insufficiency. So, for example, in children with an ileal. Oh, next slide, please. Next slide, please. ileal resection. But I think what's important to know is that they can cause osmotic diarrhea because they're rapidly hydrolyzed. And if they're then not fully digested or absorbed, they can cause diarrhea, particularly in children with a jejunal ileostomy or ileostomy. I think that's important to know. Next slide, please. And I think that's the end of my part of the talk. So I hand over to Elena. Thank you so much, Elena.
So thank you, Jutta, for your so clear presentation. You make things so difficult sounds a little bit easier. And I suppose it's really helpful for everyone attending the webinar today. So sorry, just a little bit, I will share my slides. Okay. So you will finally understand why I decided to share this imaging. It is a countryside of Tuscany, the region of Italy where I came from and where I live. So talking about the importance of MCT diet, which are the form where when we can advise to our patient to use MCT. So the most common MCT is the oil. So it's liquids and it can be used for cooking, frying, roasting, and it can also add to some wet food or even mix into drinks without changing the taste. Another option of MCT is emulsion, is consisting of 50% of MCT oil together with water. So this combination make a little bit different viscosity of the product. So it's a little bit more like a cream. And so it can be a little bit more nice to be had to milk drinks, porridge, or creamy sauce. And we can also find MCT available in powder. As dietitian, I can say maybe it is a little bit less used type of MCT, and it usually combined together with carbohydrates, especially maltodextrins and proteins. And it can also be used to baked or cooking or together with other food. About the energy, so MCT doesn't provide the same energy as 1 gram of LCT that is commonly provide 9 kilocalories. If you read the label of this product, you will read 8.5, but usually and commonly in dietetics practice, all dietitians will agree that we are calculating 8.3 kilocalories for each gram of MCT. MCT, as I told you, is flavorless, and here are some cooking tips. All of these cooking tips regard the point that the smoking point of this oil is lower comparing to the other oil, even the olive oil. So, and it is approximately 170 degrees. So it is important to consider not to leave the meal unattended because it could be dangerous. And also the advice is not to warm the oil too much or maybe reheat it again, maybe in the microwave. Otherwise it could change and have a bad and a worse and bitter taste. So this is some clinical cases I would like to share with you. The first case one is the case of Gaia. Gaia was diagnosed with a primary intestinal lymphangiectasia. She had a lymphatic malformation, and the diagnosis was made when she was 1 year and a half. So the presentation was she was having a really bad protein losing enteropathy, and she presented with one-sided lymphedema. She was Gaia at the time of the diagnosis, and all the symptoms she had. She was not having appetite at that time. Even if the day before she has been really hyperphagic because she was losing and she was leaking into the gut. Stools were 3-4 times a day. Bristol type 7. She had mild bilateral highlight edema and severe lymphedema on the left side, on the upper left side. And these were bloats at the time. So as you can see, total proteins were low, albumin were low, calcium, because it's combined with albumin, was low because she was losing everything through into the gut. Transaminases were high, and also immunoglobulin, all of them were at the low level. and this was the endoscopy she had done when she had the diagnosis. And she's particular because she's, as you can see, all the, maybe Jutta can explain better, but all the white point are the dilated lymphatics lacteals. So the therapy, she get albumin infusion, even if we know that we are replacing albumin, but lots of albumin is lost again via into the lumen. And then she started to be on an MCT diet. So as you can see, the diet was a really high protein, so hyperprotein diet. The amount of the percentage of energy from fat was around 30%, and she was receiving 8 grams a day of LCT. So every day she was using MCT 25 ml and 2 ml of walnut oil to supplement essential fatty acid. She was also receiving fat-soluble vitamin, DHA, and iron and zinc because they was low in the blood. So at the beginning, I could say yes, at the beginning, the compliance was really good. The parent was really keen to understand why she need this diet, so they study a lot, and it is really helpful when you have to follow an MCT and diet, especially a low LCT diet. So she was not having symptoms, appetite was good, intake report is good, and we could say that weight and height for age was following the centile until the age of 10. So this is me sitting on the desk in the morning in February in Florence at the Mayer Children's Hospital where I work. I received a call because it was Tuesday, the day we usually are having the nutritional follow-up of children with this special disease. They called me and they asked if I could join them for Gaia nutritional follow-up. And they told me that things were not going well as usual. Weight and height are stuck, stools are not good, bloods are worse, and then parents were really struggling and they were worried about Gaia compliance to the diet. So as you can see, this is the growth chart. This is the weight of Gaia that was faltering and also height. So what happens? The way we can assist compliance to the diet as dietitian is the food diary. I usually ask patients because 7 days could be really a lot if you have to do lots of time during your life. So we usually ask for maybe 3 days food diary, asking that one of these days is Sunday or Saturday or at least one of the weekend day. When it's not possible to collect a well-done food diary, then we have the 24 hours recall. And this is what I did with Gaia. So we start from the beginning. Gaia was always being advised and recommended to use 35 ml of MCTs every day and maybe some more oil to cook if you want to increase calories. She reported that she was not measuring the amounts of MCT, and we together estimate that she was receiving less than 35. So breakfast was good. She was using skimmed milk or yogurt, so it was good. Fruits and bread with honey. Lunch, she was having sandwich together with fat-free turkey or one slide of fat-free cheese. So she was calculating the amount of LCT that she was used to do. She stopped to have the snack in the school as she usually was done, so it was good for calories because she would do the same things like her schoolmates were doing. After school, then she was having a snack with 1 gram of LCT, usually from yogurts, and then fruits and some salty snack without LCT, so popcorn or some low LCT crackers. And dinners, it was usually having pasta or rice or bread, so complex carbohydrate together with high value proteins with fat, with low fat. So chicken breast, so without the skin, as Jutta told us before, because it's full of LCT, or white fish fillet or tuna, but not in oil, eggs white, fat-free cheese, or 1 gram fat, low-fat ham, sorry, 1 gram that ham that is low-fat, beans or lentils. So this was the dietary assessment, 1,100 calories more or less, protein were 1.9, so good enough, and 6 gram of LCT. So apparently we have less calories, but fat estimation was good. Then I start to talk with Gaia. Gaia seems really sad. She was not happy as usual, and she say, I'm struggling with the diet. I feel I'm totally different from other friends. So what was the point? And I would like to share with you this case. In different country, we could be struggling to advise and let our patient follow this difficult diet during life. So in school, sometimes in some school has in Italy an healthy diet program in which they speak about which could be a good diet, healthy lifestyles. So they speak a lot about the Mediterranean diet, like the best diet in the world, like an healthy diet. And of course, the olive oil is one of these points with the polyunsaturated fatty acids. So Gaia start to think about why should I have these lots of LCT and not olive oil. And then this is a funny picture I would like to share with you. They went to a recent olive harvest with relatives and friends. We are in Tuscany, as I told you, and it is tradition. It is not only work, it's tradition sometimes to share this period of the time with family and friends, collecting olives all together. And so what happened in Gaia is not, she always been really compliant to the diet, but she was feeling such different from her friends. And then she started to have our typical dishes, bread, it's not salty bread, like bread with oil and salt. So we calculate that someday she arrives to have an amount of LCT around 30 grams a day. So she was not tolerating that because there were too much for her. So she started to have loose stool, reduced albumin, calcium, and zinc. So from a theoretical point of view, from a dietetics point of view, I then calculate again which could be their energy requirement, estimated energy requirement with the Schofield equations and calculating calories for catch-up growth. And it was an estimation around 1,700. And if you think that from all this calorie, 20 to 35% of this calorie could be from fats, we could have around an average of 52 grams of fats every day. Her current intake of LCT, the one she was well tolerating, was around 6 grams per day. And then it means that we need to add some of like 45 grams of MCT every day to reach this percentage of energy from fat. So the suggestion with Gaia was again to start with 30 ml of MCT oil and start to count these again in this particular time of her life. Maybe later we could just stop counting the MCT oil again and increase slowly to arrive to maybe 40, 45, 50 ml a day. And then I advise Gaia to start to take an oral nutritional supplement. So in literature, we have results that the use of oral nutritional supplement in children with faltering growth could be useful. So each brick of oral nutritional supplement, juicy one, has 300 calories, fat-free, so no LCT, and 10 grams of high value protein. It could be really important in this period for Gaia where we need to reach a catch-up growth. So as you can see, just to go a little bit calculating, as you can see, the total amount of fat she could have during the day, LCT was 7 grams. We need to consider that the walnut oil we want to give to Gaia, considering then each 56 calories, we need to have 0.1 ml of walnut oil. So we need to consider the amount of this oil full of essential fatty acids to be deducted from the total amount. So she was receiving 3 ml of walnut oil every day. It means that she could have then 4 to 5 grams of LCT available. The hardest work with Gaia was to start and work together again to better understand why she needs MCT diet, why she can have more than 6 grams of LCT, comparing to children that are advised to have lots of LCT from olive oils. So we worked together also with some imaging and draft to understand what was going on in her gut. And we found together some tasty, fatty-free recipes and reviewing with Gaia how to read food label. As I told you, parents were really good doing that, but Gaia was growing up and then she was not more a child. She need to be a little bit more independent. And so we take time to let it be possible. And we also organized together a list of 1 gram LCT foods. So the aim was to normalize stools, bloods, catch up growth, and of course also the linear growth, and try maybe when Gaia will be again stable on her diet, we could maybe try to see if she can tolerate a little bit more LCT, but not from 8 to 30 grams of LCT a day. So this is then finally the growth chart after a really then she have a nutritional follow-up a little bit more frequent just to support her in this particular period. And as you can see, the growth charts of weight was a little bit better. Sorry. And this is the final case, is just a short one. Anita was born in May 2011, I'm sorry. So it's a really long case, years ago, but it was the first case when I started to work with the intestinal failure unit. And we are still following her. And finally, last year, she stopped to be on PN. She is a girl with an Hirschsprung disease. Due to the surgery, she has an intestinal failure due to short bowel syndrome. And that you can see in the picture is the bowel of Anita when she was around 1 month of life. Just quickly, 3 months of age, she started to have the serum bilirubin increase, as you can see, and all the transaminase, ALT and AST, both were high. Everything was done to reduce the rate of intestinal failure associated liver disease that she has developed. So she was receiving PN 7 days, so every days of the week, 3 days of lipids, and she was using the SMOF. She was receiving antibiotics therapy as decontamination, ursodesoxycholic acid, and minimal enteral feeding. It was started as soon as possible after the surgery. So as you can see, the first month she was receiving breast milk, only minimal enteral feeding, so 20 calories, 4 kilos. And there is not an optimal way to give enteral feeding. She was receiving with NG tube, so she was having a little bit continuously to make it a little bit more absorbable. But she also was receiving like bolus during the day, small bolus, because it was more physiologic and more stimulating hormones better, and it is really good at the important phase to make intestinal adaptation possible as soon as possible. So going back to the amount of fats, she was receiving 4 grams of LCT. Then what happened? She started to feel worse. She started to have really high stomach output. Remember, she has a really high ileostomy, and we decided to stop breast milk and shift to extensive hydrolyzed whey protein formula. And the amount of fat was 50 LCT, 50% MCT, so the same amount of milk. At that time, she was on total PN, so total parenteral nutrition. So what happened when she was 6 months? She started to increase oral feeding, then she stopped to receive milk with NG tube. It was removed, and the stomach output was in range around 30 ml kilos a day. I didn't report here, but also electrolyte and fluids were really balanced, and PM decreased a little bit of 10%, as we should say now the parenteral nutrition dependence index was a little bit lower. I report both because maybe some of us are still used to use the percentage of energy provided from parenteral nutrition. So she started to do weaning with the MCT oil, because at the time, as you remember, she has an liver disease. So in this case, we could provide a fast energy that she didn't require bile to be absorbed. But we need to increase it really slowly because she have an ileostomy, as also Jutta told us before. Could be really good for energy, good for absorption, maybe not good for adaptation, but for sure it increased the osmotic loads. So we need to introduce really slowly and to have an eye of the patient and understand if he can tolerate. So when she was 1 year and a half, then she was receiving 80% of energy from PN. She was in that period, she was well balanced. Also, the bilirubin was going a little bit down and transaminases too. She still was on extensive hydrolyzed formula with MCT that was 50%. And then she was having lunch and dinner. She was a really happy baby. She was happy to eat. And we need to work with these children as soon as possible, just following them, just trying to avoid a food aversion later, because we need to consider that they receive lots of energy with parenteral nutrition. So she was having a small amount of cereal, cream, or pureed potatoes, some Parmesan cheese, meat, fish, egg, and MCT 5 ml twice a day. So the amount of MCT were 13, and she was well tolerating then. So what is the manage of MCT? So this was the diet of Anita. Then she have really, one day she has a really bad gastroenteritis, and so stoma output were really high, and then we decide to remove all the MCT and from the diet, of course, just to remove the osmotic load. And after everything, they were slowly reintroduced and maintained. So I take over to Jutta because I finished the 2 clinical cases, and I will be happy she will conclude this joint webinar, that it was a pleasure to share with her.
Yeah, thank you so much, Elena. The pleasure was on my side. So to conclude all of this, MCT diets can be successfully achieved in infants and children despite their difficulties. Indications from a gastroenterologist's perspective would be intestinal lymphangiectasia, short bowel syndrome, intestinal failure-associated liver disease, exocrine pancreatic insufficiency. I think if you do inpatient nutrition rounds, you may come across some children on the cardiac wards with a chylothorax, and their input might be beneficial simply because we're used to applying this principle of an MCT diet. I think, as Elena demonstrated beautifully, a strict minimal LCT diet can actually be quite difficult to achieve in older children if they're no longer formula fed. Essential fatty acid supplementation, for example, with walnut oil, should be considered depending on the type of diet followed. And they're certainly required in children on an oral minimal LCT diet because it's otherwise very, very difficult to get enough EFAs from the diet. And I think that's probably all the two of us wanted to say and summarize in the end. So thank you very much. And perhaps there's time for a few questions.
Thank you very much for both of your presentations. Really great talks, and these are quite. This is a quite advanced diet, and you really emphasize that you really should work close with the dietitian to make this diet possible at all. So we have some questions in the Q&A, and if there's anyone else who wants to ask a question, you just go into the Q&A and write your question. So first from Jutta, there's a question here. In protein-losing enteropathy and chylothorax, what is the duration of the MCT diet? Is there any good evidence of how long you should continue? I think this is for Jutta.
Yeah,
probably.
I mean, so it depends. You may recall the slide where I showed depending on the drain output. So if it's minimal output, so low output, so less than 10 mils per kilo per day in infants certainly, then we give the diet for 2 weeks. If it's sort of medium 10 to 20, we give it for 4 weeks. And if it's above 20, then we start parental nutrition. And as the output comes down, so the PN for 5 to 7 days, as the output goes down, they then move to the next lower level of the pathway. So then MCT for 4 and then 2 and then stop. And then the ultimate goal would be to re-establish a normal diet. Our dietitians do count the LCTs. I think the advantage is that certainly what coronary intensive care is considered, most of the children who have cardiac surgery are for those who are born with congenital heart disease, and they would be on an MCT-rich infant formula. I think what's important to say, I think if I always feel for breastfeeding mothers who are expressing, I mean, we always encourage the mothers, please do express breast milk, freeze it. And if you think a minimal drain output of less than 10 per kilo per day, if you think 2 weeks, okay, as a mom, you think I can do this, I freeze my breast milk, I can thaw it and use it. I think 4 weeks is already difficult, and any longer is probably quite difficult for a mom because she may also end up not being able to use some of the milk. But we always encourage it. But there is some evidence for this, but this is also a protocol that I think developed over years at Great Ormond Street, where we have the largest service for children with congenital heart disease who undergo cardiac surgery, certainly in the UK. So this is also something that's, as so often, I think, in medicine, based on experience. And yes, our dietitians, if the children, or we have older children at times, if they're eating an oral diet, then they would obviously calculate the LCT content of the diet and advise accordingly.
Right. And there's also a question here, both from Jutta and someone else, if there's are medical risks with the MCT diet, if there's a risk of liver damage of such high quantities of MCT fat?
Sorry, for whom was the question?
It was also from Jetta. There were several questions. If there's a risk of liver damage.
So, I mean, I'm not a hepatologist, so I'm not aware of liver damage. I think the medical risks are the essential fatty acid deficiency. So if you don't supplement adequately, then that's a real risk. I think, for example, in children after a colectomy, so MCTs contain glycine, and that's got a very high osmotic load. So let's say you have an ileostomy after a resection, you have high stoma losses with electrolyte and fluid shifts, and then you're giving a high osmotic load, which can then aggravate your stoma losses. That can obviously be difficult. So I think you need to be aware of this. And this is, again, it's got a lot of advantages in children with short bowel syndrome. Let's say you ended up with an ileal resection, you've got bile acid deficiency because your circulation is interrupted, then the MCTs have a role, but you also have to be careful. If you've got short bowel syndrome, most children will have a faster transit. If you then give something with a high osmotic load, you may actually be counterproductive.
Right. And for you, Elena, the downsides of the MCT diet when it comes more to the social aspect, you were touching upon it with this case of Gaia. And as the children grow older, if they continue with this diet, could you expand a bit on that?
Yes. So I think at the beginning, as could be difficult for mom, because we know lots about breastfeeding and lots of mom receive lots of information how is important for children to be breastfed. So the beginning we need maybe to support mom, because we need to shift to formula, because as Jutta say, even not in Italy, we don't have the possibility to have the skimmed breast milk. And then at the beginning, it's important to let parents become really knowledge about this diet, and they really became knowledge about that. But as I show in the clinical case, like Gaia, what was happening at home was easier because she was used to MCT taste that is flavorless. She knows lots of recipe, and she can, and also I think then she became a little bit more used to different taste. So this type of children with this disease, they don't have junk food a lot because they're not allowed to have. So they have maybe a different taste. But when the social events or social pressure became a little bit higher, and we know how is important maybe to share foods together, then it became really difficult. And what I think it's our role, we need to know everything about the diet. We need to give this information to parents because they can then use, but also to children or adolescent or teenager, because they can then understand really why they need to have an MCT diet instead of an LCT one. And what Gaia and maybe other children felt on herself was that she was having LCT, but she was going really bad. She was going every day, 5 times a day in the bathroom, and then doing a better time she recovers. So these children have a different, I think, a little bit feeling with mouth, with taste, and with bowel. It all connected, and we need to support and teach them how to manage as much, as much as possible. So yeah, thank Ellen to stress this.
Yeah, and to have those practical tips to really make it easier for them to be more similar to their friends, what they are eating, maybe.
Yes, yes. So that's why we decide to have a list, because we have, for example, in Tuscany, lots of ham. So there are some brands that provide really fat-free ham or fat-free turkey. So something that could help us to have sandwich like the other one. And so this is what we are, doing every day in practice. And yes, but...
Okay, thank you very much. I think we have time for one more question. And there's another question here in the Q&A. How many times, so this is for Jutta, how many times do you see recurrence of the chylothorax after an MCT diet?
That's a very good question. Sometimes it feels a lot and sometimes it seemed to work. I think in absolute figures, I couldn't tell you, would actually have to look at our data, which is maybe a good suggestion for a thing to do. I think generally as a broad rule, if it's a low output brain, so less than 10 mils per kilo per day, it tends to improve after the 2 weeks. And if it's medium, then sometimes we are successful after 4 weeks, but it can reoccur if you introduce LCTs. And certainly in the children who require gut rest and parental nutrition, it seemed to be more difficult to reintroduce an LCT diet, simply because their underlying problem is much more severe. And I think a high percentage of those would then end up either with a prolonged period of parental nutrition and then an MCT diet, or potentially go on to surgery to, for example, have their thoracic duct ligated.
Right. Okay, thank you both again to Jutta and Elena for giving this webinar. And thank you everyone who has participated, and hope to see you again in some other webinars. You can just follow ESPGHAN on the social media platforms and look out in the webpage, and you will see all these webinars and you can register. Thank you so much, and bye-bye everyone.
Thank you, everyone.
Thank you so much.
Thank you.
Have a lovely evening.
Pleasure.
Bye.
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 Bye.